So good evening from Shanghai. Good afternoon to those of you following us in Africa, Europe, and the Middle East, and good morning to our participants in the United States. And one of our panelists is even joining us from Sydney today. Thank you so much, Eddie, for doing that. We know that it's very late for you. So my name is Erik Berglof. Since the beginning of September, I'm the chief economist of the Asian Infrastructure Investment Bank, AIB. You're all very welcome to join this webinar, which is part of a series organized jointly between the Center for Economic Policy Research, the LSE, and the AIB. We have named this series the Global Commons Room because we want to discuss our common global challenges and how research across disciplines and across different parts of the world can help us make progress on addressing them. Today's topic is living with COVID-19. I'm actually speaking to you from my quarantine in Shanghai. So for me, the impact of the pandemic is very immediate. I have had the opportunity to follow COVID-19 play out in many different countries across different parts of the world. And in every single country, lives and livelihoods have been affected, but the impact differ greatly depending on where you live. So understandably, the focus so far has very much been on the short-term impact, as people were losing their jobs and many died and many more were infected and fell ill. Many governments, not the least in developing and emerging economies, they responded with strong lockdowns and social distancing measures, often with very different results. But now, of course, pressures are building on these governments to open economies again. But it's very important that we also consider the medium and long term to make sure that we don't undermine the long-term capacity of societies to defend themselves against this virus and future viruses. I've had the fortune to be part of a horizon scoping exercise initiated by the Wellcome Trust, one of the largest funders of research in the world. And we were a group of scientists, mainly virologists and epidemiologists, and some global health experts and social scientists. And I was a token economist in that group. For me, this was an incredibly interesting process, and we had a chance to look at 4 different scenarios shaped by scientists on the panel. And together with the global health experts and the social scientists, we looked at how these 4 scenarios would play out in 5 different social and economic settings. And above everything, we found that really independent of any assumptions you make about the development and distribution of vaccines and antivirals, or about the evolution of the virus or assumption about immunity, we will be living with COVID-19 for a long time, at least several years. So we have a fantastic panel to discuss these findings. We have a couple of participants from the exercise on the panel, and I will let them present the findings. But I've also invited 2 commentators from different parts of the world and with different perspectives to come in and comment on the findings of the report and make their own observations. Before we start the initial remarks, I just wanted to say a few words about the plan for the rest of the discussion. We'll first have some introductory remarks and from the panelists, and I will then invite 2 students from the LSE to ask the first questions, and then take questions from the rest of the audience. I have asked the panelists to contain their initial remarks so that we can get time for the questions and answers. But before we start the panel, I wanted the audience to answer in the following question, and it will display the poll. So for how long do you think that the COVID-19 will affect global growth? So there are different options here, just this year or 2020 or until 2022 or all the way to 2030. So polling is Continuing. So I know that maybe those of you following us on Facebook cannot see the results of this, but I can tell you that the majority of people, 44% at the moment, thinks it's going to be with us at least until 2025, and some 20% think that it will be with us until 2030. So with that in mind, I'm going to invite our first panelist, Professor Edward Holmes. He's a world-renowned evolutionary biologist and virologist at the University of Sydney. He has worked on viruses in many countries around the world, but he has particularly collaborated with Chinese scientists in the mapping of the genome of this SARS-CoV-2 virus, the virus behind the COVID-19. This has meant that he got involved very early in the Wuhan outbreak and could follow its evolution and the Chinese response. So Eddie, the virtual floor is yours.
So I'm just going to take 5 minutes, and I'm just going to very briefly give you the kind of biological framework from which we built these possible futures for how COVID-19 may be we do this for sort of medium and long term. So be very brief. So just going to show you the kind of framework the foundations for how we then understood its impact on society in the longer term. And the way we did that was really quite simple. We just considered 6 features of the basic biology of the virus and how that virus interacts with humans. And the features were immunity, so how long, if you're infected, how long your immune response will be to the virus and how protective will it be. Vaccine, so how long will it take to make a vaccine to the virus and how successful will that vaccine be. Antiviral is very similar. You know, how long will it take to get the good drugs to the virus, how successful will it be. Antigenic evolution, which means will the virus eventually evolve to escape immunity, to escape vaccine, rather like influenza does, measles doesn't. The evolution of virulence and transmission. So in the future, will the virus evolve to become more or less virulent through time? Big debate about that, obviously. And how the virus might interact with other pathogens, for example, other common cold coronaviruses that may provide immunity, or other comorbidities in the population. We also considered kind of seasonality in there as well. So there are kind of 6 features. And then for each of those features, we considered the reasonable best, middle, and worst case scenario for those over a kind of 5-year period. So in the case of vaccines, for example, our best case scenario, and you can debate these, the details are not particularly important, this kind of exercise is the key thing. Best case scenario for vaccines, we thought, okay, maybe we'll get a vaccine in 12 months and it'll be completely protective and long lasting. That's the best thing we could think of. That vaccine, in the best case, will also be very quick and easy to produce in large quantities. And there'll be no what's called antibody dependent enhancement. That means that another virus in the population could make the COVID-19 vaccine become kind of nasty or lethal. So there's no interactions with other viruses. The middle case scenario would be the vaccine actually takes a bit longer to make, between 18 months and 2 years, that it's not completely protective. There's some variable immunity, and there are some difficulties in actually developing the vaccine and making a good supply chain. Maybe there's some vaccine failure, maybe the virus evolves to escape it. That's a kind of middle scenario, and it might take a few months to make enough doses to actually deploy. And the worst case scenario, of course, is that there's no vaccine in the next 5 years, and you can't even induce a strong immune response. And if you did get a vaccine, there will be these strange interactions with other pathogens like antibody-dependent enhancement will actually have negative consequences on health. So actually vaccination is actually very hard to do and could actually be detrimental. So you've got a range of scenarios. And then basically we did that kind of mapping, best, middle, worst, for each of those 6 traits. Okay, so you have this kind of lattice of all the possible, all the features, and all the possible worst case scenario, worst, middle, and best case scenarios. Now, of course, you can't think about every possible combination of cells in that lattice. It's too much. So what we then did was just, let's think through 4 different futures, so 4 different pathways through that lattice of possibilities, of that scaffold of what the virus might do in 5 or so years, and use those as a kind of a guide to help us think about the virus in the future, disease in the future, that we can then build on that. We can build looking at the social, political, economic kind of consequence of that. And the 4 pathways, the 4 futures or pathways we chose, again, there could be others. These are the 4 we thought were quite useful. 4 of them, and I gave them kind of nicknames just to kind of make it easy to refer to. So one is just called vaccines work, antivirals fail. And it's obvious what that means is that we can get a vaccine that works pretty well, but we don't get a decent drug. And the virus doesn't really change in its virulence through time. It only has a little bit of interaction with other pathogens. The second one we had was called, it's kind of the opposite, that says antivirals work but vaccines fail. So you can't really get a vaccine because you don't get a good immunity, but we can make some antivirals. And again, the virus doesn't really change its virulence through time. The third one was in some ways more optimistic. It said, look, medical interventions are effective, so vaccines and drugs can work, and the virus does not really evolve away from those, okay? So we get pretty good vaccines, and they don't really escape from, the virus doesn't really escape from those interventions, those drugs and those vaccines, and the virulence of the virus gradually evolves downwards, becomes less virulent through time. And the worst one, the fourth one is actually the worst case scenario that Eric was very keen to have in there. We called it medical interventions fail and evolution works against us. So we don't get a vaccine, we don't get a good antiviral. The virus also begins to evolve antigenically. That's going to make getting a vaccine even harder to make, and virulence may go up as well. And also, it doesn't become seasonal. And seasonality, although it has complicated effects, it may actually, if you know the virus, you know your disease will be concentrated in one part of the year, maybe that helps you plan. So they're the kind of features we had, the 4 pathways. And you can draw these little diagrams. This is my last slide. You can kind of draw these sort of little diagram tables like this. So here are the features, and here are the 4 possible futures there across the top. The details not really that important, but the cells are color-coded just to show you that each of those futures is actually a combination of best. So that's the light, that's the kind of no shading, that's the good possibilities for 5 years. A middle case are the light grey ones, or worse, that's dark grey. So remember that future 4 was medical interventions fail and evolution works against us. And that was our worst case scenario. So all the cells are grey. But as you can see, there are many different ways you can go through that lattice. And we just chose certain ones to kind of explore the parameter space that you could then build on, thinking about the social, political, economic consequences. So these should not be thought of as our hard and fast predictions. That's not what they are. They're just a guide for thinking about the future for COVID-19 in the next 5 years. And also maybe, as I was hoping, they're a way of thinking about other diseases in the kind of longer term. I think, as Eric emphasized at the start, we tend to think on the kind of immediate short term, but maybe the longer term consequences are also a thing we have to consider. I'm just going to stop there, Eric. That was my presentation.
Okay, thank you very much, Eddie. And I think you have really set out the challenge here for Caroline. So I said that in the group there were global health experts and other scientists, social scientists as well. And Caroline Buckey, who is an associate professor at the Harvard T.H. Chan School of Public Health, and also associate director of the Center for Communicable Disease Dynamics, she was also part of this group, and she has now the unenviable task of summarizing what we thought about how these different scientific scenarios play out in different economic and social contexts. So Caroline, please.
Thank you, Eric. So the caveat here is that I'm an infectious disease epidemiologist. So rather than laying out the archetypes, of course, no country is an archetype. And again, this was a sort of thought experiment more than anything else. So what I'm going to do is just lay out the considerations, the different aspects of countries or societies against which this virus is spreading, and the biological features that Eddie talked about will actually manifest in populations. So let me just share my screen. Okay, so I've just picked, again, these are just kind of to think through some of the features of populations that make epidemics harder to control and will determine some of the longer term impacts of COVID-19. The first obvious one that we've all heard a lot about is demography. And so these are population pyramids showing the age structure of different countries, for example, UK, India, and Nigeria. And already there's been a lot of debate about this because the highest risk group in terms of mortality from this virus is, of course, people over the age of 65. And there are very different fractions of society that fall into that high risk category. And that's really one of the biggest explanatory factors for mortality rates so far, and will continue to define the risk groups that our populations fall into and what we will expect in terms of vulnerabilities and mortality rates. It's not just the population pyramids overall, it's also how society is structured. So these bars just show the household structures of these different countries, where the number of people living in each household is shown in these bars. So in India, we have more large households, multi-family households with multiple generations compared to the United Kingdom, for example. And this is really important because, under these lockdowns that we've been having in general, household transmission becomes an important feature of whether the epidemic is spreading or not and how transmission happens. And so it's not just the age structure of the population, but also how our society is structured within households. And that will continue to be something that needs to be thought about when we think about vulnerability to resurgence and what we might expect in the future. The other thing that I think is really important that is going to impact both how this goes over the next 5 years, but also what other things might be happening as well, are the competing priorities that health systems have to manage. So this is a graph from the IHME's Global Burden of Disease tool, and it just looks at all of the health burden in a country, and then the area of these squares represents the burden of those things. And so for the United Kingdom, for example, infectious diseases are just a relatively small fraction of the burden of disease overall compared to non-infectious diseases and accidents and injuries. And so the burden of chronic disease, cancer, heart disease, and so on, these are going to be the competing priorities for health systems moving forward. If we compare that to low and middle income settings, where we often have a much, much higher burden of infectious diseases in the population. And this is important because as we've taken the accelerator off other interventions, for example, malaria and measles and so on, we're battling the same nonlinear growth that we see in COVID-19. And so a lot of countries are going to be fighting these competing health priorities, and infectious diseases in particular may become an important part of what health systems are going to have to deal with on top of COVID-19. The other thing we've talked about in these archetypes is the sort of spatial and population distribution aspects of a country. So this is the US, of course, and this is split up into kind of the places that were hit early in the epidemic versus later on in the year. And so, of course, we have these large cities where international travelers come in, and then we have spread beyond that. Here we have New York, which was dominating at the beginning, and then later on it spread to other parts of the country. In large heterogeneous populations where we have large cities and then large sprawling urban populations, this epidemic is going to continue to show substantial spatial and temporal heterogeneity in terms of how it's spreading and which pockets are still susceptible. And that's going to be important for vaccine distribution, logistics, and managing the longer term impacts in general. And then I think, you can see these kinds of population structures play out. And again, I haven't talked about GDP, but some of these things are clearly linked to GDP in terms of resource constraints and how the health system can respond, but not entirely. There's a lot of political and social dimensions here. So I've just highlighted some countries. Again, these large heterogeneous countries like India, the US, and Brazil, which have a relatively weak federal control over the situation and a lot of heterogeneity in space and time. Islands, small countries that are relatively homogeneous, like Iceland and New Zealand, have done pretty well over the course of the epidemic. And I think we'll continue to see them able to deal with any importations. And then countries in the middle here, and of course, China is a large heterogeneous country. And this is just to kind of highlight the difference between different kinds of political systems and how well they're able to cope with this virus. A big issue is the health system itself, right? And so testing has been one of the primary distinctive challenges of this outbreak. And I think it's really distinguished which countries have done a good job and which countries have not. And that will continue to play a very key role. So to the extent to which testing is a good proxy for how well the health system itself is going to function moving forward, I think that's going to be a defining feature of which nations are able to cope with this and which regions are going to do well. And again, New Zealand has tested many people per confirmed case of COVID-19, and then relatively fewer in these larger countries that are more difficult to manage. A huge aspect of this that we covered in some of these archetypes was the issue of trust and the importance of trust that people have in a public health system and in the government. And I think that has also been a really defining feature of this epidemic, particularly as the non-pharmaceutical interventions that we will continue to rely on in the coming months at least, but probably in the coming years too, really rely on individual people following rules and are being compliant. And that, again, you can see that the countries that are most trustful have done relatively well in terms of controlling their epidemic. And that relationship between a population and its government and how much it trusts it will be absolutely key for the continuing mitigation of transmission, as well as both the vaccine distribution and uptake. So I'll just end with this. In the US, there's been a decline in public trust in government over time. And I think that really has played out very clearly in this epidemic. Here you have a map from tweets on Twitter about anti-mask sentiment. It's very heterogeneous across the country. And again, just from an infectious disease epidemiology perspective, when we're asked to make forecasts, what has become clear to me is that the biological and epidemiological features of transmission are relatively well understood, but the social and behavioral dynamics that are underlying whether this epidemic is contained or continues to spread are really hard to predict, and those are going to be some of the main features for what we can expect over the coming years. So I will stop there, and I will just end by saying that, in the archetypes that we laid out here, we try to address these different aspects of society that will make it easier or harder to manage the biological threats that come from the possible futures that Eddie outlined. And they're not supposed to be representative of any particular country. They're just supposed to highlight some of the aspects of societies that are going to make this longer, shorter, more or less difficult to manage. So I'll stop.
And of course, you should emphasize also the heterogeneity within these contexts and within low-income countries and within, between urban areas and rural areas and so on. Yeah. But and of course, the trust issue is very important for vaccine, as we will come to probably later in the discussion. So the next speaker is Gabriel Leung, professor and dean of the medical faculty at Hong Kong University. Gabriel is a physician with a specialization in population health. He's worked across disciplines and taken sort of major health issues and looking at the local impact. He's also served as a Undersecretary of Health in Hong Kong and as director of the Chief Executive's Office. So Gabriel, you were not part of our group, but you helped us with many valuable and constructive comments. So I hope that you can give some comments again here. Please, Gabriel.
Thank you very much indeed, Eric, and delighted to be here. And thank you, Eddie, and thank you, Caroline, for your summary of much of the work of this piece supported by the Wellcome Trust. Let me perhaps just highlight a couple of points, one from each of the two presentations that we've just heard. So I think that what we have just heard from Eddie are different combinations and permutations, particularly focused around the issues of vaccines, antivirals, or medical interventions generally, and then also about viral evolution. And then focusing in on the medical interventions, including vaccines, antivirals, immunity of the host, and then the evolutionary bit about antigenic evolution and also evolution and virulence, and whether there is a seasonal kick that goes along with it. So let me pick up on that point and perhaps talk about vaccines, which is a large part of the matrix that Eddie presented just now. I think that the first generation of COVID-19 vaccines that we are all expecting over the next months, perhaps, I think that there has been a lot of maybe misperception about what kind of COVID-19 future it might or might not be able to bring. And generally, I think that there's been an assumption that having a safe and effective vaccine would lead to resumption of pre-COVID normalcy of some sort. But I think that quite a few of us have not really sort of dissected or teased out what the real outcomes of interest that are being currently addressed by these vaccine trials. What is being addressed and what is being looked at, the primary outcome is really to see whether any of these vaccines would reduce disease risk, but not actually infection itself and therefore transmission. Now, there is a very subtle but very important distinction. If the outcome is to look at whether vaccines can confer protection from disease or severe disease, then what we may or may not be able to expect from it in terms of returning to normalcy is really not being looked at as a primary outcome. What would actually be a real game changer is whether these vaccines can prevent infection and provide sterilizing immunity, mainly in the upper airways where you actually shed and therefore pass it on to others. Now, if you actually look, probably none of the 8 or 9 or 10 vaccines that are now in phase 3, and therefore most likely to form the first generation of vaccines that would be deployed, none of them, with one exception, actually even claims that they provide sterilizing immunity in the upper airways. And for that one, we do have results, but by press release and not yet in peer-reviewed publication. The second thing that I would point out is what Eddie also actually mentioned in his matrix, and that is the immunological correlates of protection. That is, other than antibody levels, are there other things, and of course there are, that actually might confer protection? And even with antibodies, is it just looking at neutralizing antibody, or maybe we should also be looking at cell-mediated immunity, mucosal immunity, or other biological antibody activities like antibody-dependent cellular cytotoxicity, or what is the role of T cells? So I think that that's very important work that we're still waiting for. Then, as to some of the sort of dichotomy that Eddie referred to in terms of how long do we expect the protection to be following natural infection and recovery or following vaccination. So there has been a huge number of studies on antibodies and waning antibody levels, but they all use slightly different methods, and therefore they come up with wildly different answers. I'm not going to go into the technical bits unless in the Q&A people are interested, and then we can talk about those. But I think that if you actually look at the more carefully done studies, then you are looking at some fairly encouraging findings. That is, after 5 or 6 months, virtually all of the recoverers from natural infection, they would still have positive antibody titers by neutralization as well as in the ELISA. And we've done some work that is about to go into press that says that older folks, 60 and over, compared to younger folks, they actually make at least as good antibody titers as younger groups, even accounting for disease severity. And so I think that on that front, we can be fairly confident. Now, exactly how long this would actually last, nobody knows. And maybe that we would need revaccination, even after a 2-dose prime boost regimen. But if we can actually get over that first hump next year, and then we can start worrying about how do we make second-generation vaccines that might actually protect us in terms of protecting us from infection and therefore transmission itself. So I don't think I'm going to belabor any more on these points, but then move on to my second point about Caroline's very helpful presentation. And the one thing that I would like to add is that I think that COVID-19 will turn out to be, if it hasn't already, it will turn out to be the gravest single health event that gives us the deepest inequity that we have seen in recent times and probably in the last century. And that is both by omission, that is what we have not done to prevent it, as well as by commission. Now, the omission bit, if you actually look at any country with any kind of socioeconomic position, racial, ethnic lines, you will see that it is pro-rich. That is, the rich, the more advantaged groups are more or less more protected compared to the other side of the socioeconomic and racial spectrum. Then the commission bit is what I worry about even more because it is so preventable, and that is concerning vaccine allocation. It is both between countries where you see most of the rich countries of the world, including many in G7, striking bilateral advanced purchase agreements with Big Pharma. And there are important countries that have deliberately not participated in the WHO CEPI Gavi-led COVAX facility. So that's at the geopolitical or geostrategic level. But within countries, how do you go and distribute and make sure that maybe with the exception of the J&J vaccine, if it works, everybody else needs to have a cold chain transport. How are you going to maintain that kind of integrity in at least half the world where you cannot find such massive cold chain logistics available? And then even if you have that, how do you actually decide who gets it first? Because it would take an enormous amount of time. We're talking about months, if not a year or two, to actually vaccinate the whole world. So who goes first, who goes second, and who comes last? So that's the by commission bit. So I think that we need to do much more to address it, not least because we are living through, and we have actually pre-COVID been living through one of the most unequal eras in human recorded history. So let us not make this COVID pandemic yet another blow to that equity agenda. Over.
Thank you very much, Gabriel. Very important points, and we will come back to them, I'm sure, in the discussion. So the final speaker is Astrid Haas. She is the policy director at the International Growth Center, which is a collaboration between the LSE and Oxford. Her current research specializes in sort of municipal and infrastructure finance. In particular, she's been working on urban mobility and urban land tenure and so on. She's worked also with a lot with individual mayors, city managers, and their teams in Africa. So I'm particularly pleased to see Astrid here because I was part of the panel that selected her for her current job. And so IGC is very fortunate to have you, Astrid. So please give your perspective from Kampala, where you are now locked down, I understand.
Thank you very much, Eric, and thanks for inviting me. So my comments are going to primarily focus on Caroline's presentation, because I will caveat I am definitely not a health expert by any means. I'm very much an economist. And so I want to draw out some of those inequities that Gabriel was mentioning in his discussion, and how that is likely to play out, just based on what we're seeing now, could possibly play out in the context of Uganda, but also many other countries that I work with across the continent. But let me defy that right at the beginning and start by actually talking about the health, because I think that's really important when we consider the long-term vision of what that means for sub-Saharan Africa. And in particular, you know, we saw the policy mimicry right at the beginning of this pandemic, and Africa was the sort of last continent to get the wave of COVID. And so by the time it came here, we had all of these health models that predicted disaster, because obviously we have the weakest health systems across the continent. And there's, you know, many statistics that I could throw out here that would illustrate that, but I think it's relatively obvious. And I looked up before this panel right now, what was the predicted deaths in my own country, Uganda. And, you know, we were supposed to have 68,000 deaths by now, according to some of the epidemiological models that were out there. Now, I also looked up what it is currently today. So we have a population of about 42 million. We currently have 6,879 recorded cases, and we have exactly 69 recorded deaths to date. And I don't think, and sorry, Caroline, I'm going to, again, not being a health person, it's difficult for me to contradict you, but I actually don't think we understand why yet. There's a lot of theories about we don't have all the data, but actually even those people who are looking at not just testing data, but things like excess death data, they're not seeing any spikes and they're not seeing any patterns. We have put it down to some of the really harsh lockdowns, including my own country was at the very, very harsh spectrum of the lockdown, and we're only emerging right now. But then my neighboring country, Tanzania, was even denied that COVID was a thing, and we're not seeing excess deaths there either. So I'm not necessarily sure that fully describes it. We talk about the demographics. Caroline, you highlighted that in your presentation. I'm not sure that we fully know whether that's the case yet. We talk about exposure to malaria and other infectious diseases. Again, Caroline, something you brought out in your presentation, but again, I don't think we know. And then I think something that's really interesting that's coming out of research that that the IGC is funding, and it's not yet published yet, but it, you know, hopefully in due course it will. And it matches the sort of anecdotal evidence that we have here too, is that it seems that a lot of the cases that test positive are asymptomatic. And now we don't know reported asymptomatic. We don't know whether people just experience the symptoms and just don't take them as symptoms because they just resemble, you know, here, a lot of the time when you feel a little bit of a headache, it's malaria. So we don't know whether people are just sort of conflating that. But, you know, I don't think we understand that. And so I think to understand which of the four or any of the scenarios, Eddie, that play out in your case, we actually need to understand what the trajectory of the virus is here. And I think that I premise my comments on that because whether a vaccine or an antivirals or, you know, it's all going to depend, like, what is the virus actually doing here? And I don't think we know that yet. But now to go back to my own sort of place of comfort and on the economic side, I do think we're starting to get the picture, and it's very grave about how this has played out economically. And I think this is where we're going to see the long-term effects to come. So we know that the short-term, you know, we know the short-term shocks. We're starting to see the data come in. The data is really tragic and how lockdowns impacted. And in fact, some CGE modeling done by some researchers, again funded by the IGC, showed that particularly in sub-Saharan Africa, the greatest impact was not actually the global shock, except for in those mineral exporting heavy countries, but it was in fact the effect of the lockdowns that were imposed. We also see interesting data coming out now that actually we managed to weather the supply chain. So whilst, for example, in Uganda, the borders are not yet open, so we haven't been able to travel, we did manage to keep our supply chains open. I think there was an initial sort of 43% reduction in imports, but that kind of went up after a couple of months again. So we figured out the supply chain piece. We see in a lot of data in a lot of countries that, you know, businesses have started up again, you know, production is starting. But I think the big piece, and this is the part that we really need to focus on for the long term, is the piece on aggregate demand. And that's because really that's where we see it in the business data, where, you know, production is up, but sales are still down. But I think more importantly, we see it in the poverty and the livelihoods data. And this is why at the poll at the beginning, when I said how long, when you asked how long, you know, COVID is here today to stay, I said until 2030, because I actually think that's the case. We see data from Uganda that already just now, and we're as I said, we're not even past our lockdown yet. We've already eroded over 10 years of our poverty reduction efforts, just in this short period of time. We see simulations that my colleagues at the IGC have done that an 8-week lockdown would cause 9.1% of people to fall back into extreme poverty, 2/3 of that being just from lockdowns, and 168 million people across the continent not being able to be able to have their pre-COVID consumption levels. Data that's coming in here now sees rising child malnutrition, it sees rising poverty. And I think the thing that we really don't know yet on the economic side, which is going to have the longest term impact, is school closures. Schools are still closed here, and we're close to having a dead year. So that means a whole year of schooling has been lost. And I think we know the gains to human capitals, but I think we're just about to discover the losses of human capital. Secondly, I just want to pick up on Gabriel's point of the by commission piece, because I think regardless of what scenario plays out, minus the worst case scenario, because that affects us all, but in all the sort of relatively best case scenarios, I think here on the continent, we're going to have it the longest. And that's because we're going to have the supply chain issues that Gabriel alluded to. And we already saw this when PPE equipment and masks were at a scarcity. Many African countries were not at the table in terms of their bargaining power. And in fact, it was only until the African Union started pooling efforts that we could even bargain for, you know, scarce PPE equipment masks. So I have, you know, there's a lot of work being done on the vaccine supply chain, but even, you know, hearing all Gabriel's pieces about cold chains and needing to maintain that, I have, you know, I'm less optimistic that we're going to be at the forefront in the #1 group of receiving the vaccine. I think secondly, there's the type of vaccine, and this goes to my first comment, which is how is it playing out here? And I think we don't know. So therefore, is the vaccine going to work here? I think we also don't know. And I don't know how many African researchers are actually working on the vaccines as well. Just on the political side, I think there's a capacity and capabilities piece. I think it is easier to lock down a whole country when capacity and enforcement is low. I don't think that is sustainable. And so therefore, how we work in the interim, I think is going to be extremely, like with these, what's to come is going to be sort of, Caroline, your point about how we manage living with COVID. But I think there are 3 places I just want to finish on in terms of sort of where I think there is some opportunities in managing it. And this is sort of in a fiscal constrained environment. So one, I think behavior change. And I think we've seen a lot of really positive examples come from Africa with Ebola epidemic and the AIDS epidemic of how you can really use behavior change to fight a disease. However, that requires the trust that, again, Caroline, you highlighted. And I think that's something, you know, with depending on how long COVID is around for, we're going to go through a number of election cycles. And I can tell you, going through my own election cycle right now, it plays out very strongly on an election cycle. I think, secondly, it's about how we target limited fiscal resources. I don't think we've been doing this well pre-COVID. There's a lot of studies that show that, you know, in the limited cases social protection existed, we didn't even target it properly. But I do think the one thing that's happening with COVID is that we're really ramping up our real-time data collection, because we were just everyone was trying to do policy making in uncertain times. So it's how we actually embed that data collection and that for a longer period of time and help us allocate resources most efficiently and most effectively, I think is going to be a big win for us if we're able to do that. I think finally, I just want to, my final point is, I mean, I have a couple of other ideas, I think, where there are sort of optimistic pieces on how we manage this in the long term. But I do really think it requires a shift in thinking. And in my own country here and in many countries in Africa, we're still managing this as if this is a short-term thing. We're still, so for example, very concrete example, anyone who tests positive here, asymptomatic or not, was taken to the National Referral Hospital. Surprisingly, our National Referral Hospital is now full. It can't even treat any other cases. So now we've opened our football stadium. And that's, you know, that's with the sort of back thinking that you can do what we did with Ebola, is if you isolate enough people, it will go away. But it's a global disease. I don't think that will work. So we need to shift our thinking and how we live with it. And the second thing we need to do is really expand our definition of public health. I think it has been co-opted by public health equaling COVID. And I think what we see actually is quite staggering in terms of the numbers of other things. Maternal mortality rate has gone up. Tuberculosis cases, we're predicted to have maybe, the WTO, I think, has predictions of 200,000 more deaths by tuberculosis. We have a drop in vaccinations for childhood diseases. And I think these are, I mean, I can go on and on. The data is already here. And I think we need to know that public health is a bigger spectrum of what it means. But I also think in terms of public health, we need to think this is not a lives versus livelihoods question in sub-Saharan Africa. The intersection and the interaction between lives and livelihoods is just very clear. And therefore, when we weigh the opportunity costs and benefits of the policies that we put in and how we live with this in the longer term, I think that's going to sort of determine where you see, Eddie, your matrix and your scenarios playing out.
Well, thank you very much, Astrid. And there's a lot to think about what you brought up. And I think I'm going to bring it back in Caroline and Eddie, because I think you made some very important points about, of course, your three last points on what sort of optimistic side, but they of course reflect what you have seen from your experience. So the behavioral change and of course we have seen this everywhere in the world, that there has been real behavioral change, and that has actually also made some of these epidemiological models not really work out exactly as we had thought, and I think that's an area where there's a lot of scope for more collaboration between economists and epidemiologists. And you also talked about targeting fiscal resources and where you actually direct them, and the final thing is, of course, what this seminar or this webinar is all about: how do we shift to a sort of more long-term perspective? Maybe Caroline, can I ask you first to come in with some comments, and maybe Eddie after that?
Yeah, so first of all, I didn't mean to imply that I think we understand everything about transmission. And I completely agree with Astrid that, in many places we're not seeing the mortality that was expected. And, I work in the Rohingya refugee camp, for example, and it seems as if the mortality rate may be different. There's still a lot that we don't understand. So I completely agree about that. And And so that means when we're thinking about these competing priorities, I also agree, there has to be a more integrated approach instead of having a single disease dominate all of the thinking about our futures. And one thing I think that this implies when we think about re-envisioning public health, you know, I work on surveillance for other infections like malaria and so on. And often it's very siloed. And so, you know, you have malaria healthcare workers or you have polio workers, and that's what they do. You know, sometimes at the expense of a more generalized healthcare worker that can, you know, think about the whole community's health. And of course, that is what intersects with the livelihoods aspect. It's the entire spectrum of health. And so I think the long-term impacts, as Astrid says, are going to be very, very difficult to overcome in low-income settings, well, and everywhere, but particularly in low-income settings, because of this interplay between all the losses that we're experiencing right now, which might be exponentially, right? We're not just losing a year of a malaria program, we're losing years because of the fact that malaria can grow very quickly. So I completely agree about that. And then I would say, I just want to comment on the inequity issue. This is going to be a defining feature, as Gabriel and Astrid mentioned. Inequality has dominated the burden of disease so far. We've got probably some pockets of populations that actually are at herd immunity, and overwhelmingly those are poor communities. And so when we think about vaccine allocation, this is going to be an absolutely critical issue, not just who gets it first, but also who might not get it. And because we don't understand about immunity, that becomes a very political issue as well. And so I agree that the inequality here is going to determine what happens with the dynamics of transmission as well. So basically I agree with what Gabriel and Astrid said. Eddie, do you have other comments?
Not particularly. I think you've absolutely laid it out very well. I think Gabriel made some very good points actually about this belief that people tend to have that we'll have a vaccine and it'll all be over and it'll be completely protective immunity. But as Gabriel says, most of the vaccines are only realistically going to help prevent serious disease, not transmission. And so it's a very different field. And I think people will be very disappointed when the first vaccines are released and it's not quite what they think. And somehow we need to convey that in a way that doesn't make science look like it's failed in some way. I mean that is another problem, in fact. So. No, I have nothing. I think this has been so far a very interesting reality check for people like me who don't tend to work so closely with the coalface. It's very interesting to hear these things.
Gabriel, you highlighted this issue of inequalities. When you listen to Astrid, it must resonate with what you were saying. You have any comments?
I mean, I think that it's absolutely true. I mean, the reality on the ground is, I think Africa has, every right to be concerned about these gross inequalities at the international and global level, but also within the continent of Africa itself. There are massive gradients, very steep gradients. And how would you prepare for, as I said, I mean, just the single issue of vaccine procurement, vaccine deployment, and vaccine prioritization? I mean, I think these are three huge issues which even the best multinational firms who are just thinking about distributing soft drinks along a cold chain logistics would have massive headaches and probably need to plan a couple of years ahead. let alone deploying vaccines which are potentially life-saving. And so, I mean, I think that it's really a collective responsibility for the entire world to make sure that, whether it's based on moral reasons or even just self-interest, that we get this done properly and fairly, because nobody really in this world is safe until the entire world is virtually protected.
Gabriel, I assume people are making these plans. I mean, am I being overly optimistic that there are plans being drawn up to deploy vaccines?
Well, I'm sure that in particularly rich countries there are such plans of deployment, but maybe some rich countries haven't even decided yet how they might do it. Because of the issue that I hadn't mentioned yet, but of vaccine confidence. If you actually look at real-time Twitter sentiment analyses, and there are several out there, they have actually swung a lot. They've swung a lot in the last 3 months alone. You know, whether or not, let's say, for example, the US FDA, you know, when and by what criteria they might make these emergency use exceptions in terms of approval, I think it's going to swing that vaccine confidence a lot. And, you know, imagine that vaccine confidence or vaccine acceptance is somehow correlated, it doesn't even have to be causal, it just needs to be correlated with the transmission matrix, then it just basically is another wrench in any kind of vaccine allocation model that people have put out there. Although I actually read with some reassurance a piece precisely on that from, I think, Brian Grenfell's group recently. And in the sensitivity analysis, they said it probably wouldn't matter a huge amount given other constraints and other assumptions. But I mean, I don't know how true that is for the entire world. So I mean, I think that, you know, those are issues that are very important.
I should say that in the archetypes that we drew up, Eric, and you know, one of the tenets that we considered was the role of the media, and this sort of relationship between misinformation, public opinion, and how robust the media infrastructure was in different countries, because I think it's going to be very important.
Can I quickly comment?
Yeah, Astrid, please.
I think I have just three brief points to make. So one, in the African context, I think from the supply chain side, Gabby is doing a great amount of work. Unfortunately, I mean, it was interesting to read in your paper this sort of emphasis that we need global to come together, and it's very sad that in this day and age that's a really big thing you emphasize. And then particularly on the global health organizations, things are going the other way around right now when we actually need them to work together. But I do want to mention Gabby. The second thing is this trust issue, and actually colleagues of mine are doing some fascinating surveying right now, and this is just about to come out in a paper where we are in a number of IGC countries. We're asking about sort of, if a vaccine would come out, would you take it? And so I think that data is going to be really important. But where we, for example, saw a massive drop here was when, I don't know, I think it was some French minister or French politician said, oh, it should be tried out in Africa. And then there was this whole thing about the vaccine trials were going to happen in Africa. And that raised like a massive uproar here and a distrust. And then the third thing I want to say is that a couple weeks ago, I spoke to a minister in an African country, a very high-ranking minister who was trying to figure out what to do about lockdowns or not. And interestingly, he himself had COVID, and he was like, you know, it's terrible. I really suffered and whatnot. But not that many people have had it in my country. And we've been like advertising this with everyone's going to die, and they don't see people dying, and therefore they don't see, you know, why we should be doing anything about it. And that's a really difficult political conundrum, not only for the people who are trying to treat it, but it will also become when it becomes a vaccine, because COVID has been equated to death, but we don't necessarily see that as much as we see it, for example, with other infectious diseases. And so I think that's just going to be like a massive issue that we already need to start thinking about the behavior side of that to overcome before even, you know, the vaccine is rolled out.
Can I comment on that? So this is you know, we've managed to eradicate very, very vanishingly few diseases in the history of humankind. And this is a continuing problem. When you reach very, very low levels of a disease and you're nearly at elimination, nearly at eradication, it's very hard to convince ministers and people that you should be accelerating and continuing to apply interventions because they don't see it in their communities and they can't understand why other more glaring problems aren't being addressed. So I think we can also look to other eradication campaigns and see some of the challenges that might emerge there as transmission gets very low. It's quite hard to go the last mile and actually push something into extinction. So that's also going to be on the horizon.
Okay, I'm going to try to bring in some of the audience here. And I think most of you are now familiar with Zoom, and you can use the Q&A to ask questions. And while you do that, and I have already some questions here, but while you do that, I'm going to invite two students. We have a new tradition here of letting two students from LSE ask the first question. So can I ask Hassan Ghali to ask his first question?
Thank you very much. And thank you.
Maybe I should say Hassan is actually, you're not really a student any longer. You graduated from our Master in Public Policy this year, but you're also an MD, I know, so from Sudan.
Thank you. No, thank you very much for the talk. I think my question was about the scenario that we do have a vaccine that works. And the question is that it's probably unlikely that there'll be enough supply of the vaccine to vaccinate the entire population of the world. So I think then comes a discussion about the ratification process. And of course, I think a lot of us agree on the ethical framework that we need to aim at reducing the global toll of deaths, the economic strain, and reducing community transmission. But then it becomes a problem, especially in the current global political atmosphere of rising nationalism and populism, that you do have this sort of vaccine nationalism that is undermining any sort of efforts by organizations such as COVAX and the WHO, merely maybe because of their voluntary enrollment nature and the absence of enforcement capacity, and not to mention the refusal of cooperation by hegemonic states, such as the Trump administration. So my question is about political commitment, and how can we rally global political commitment, and who in the current political atmosphere, if anyone, is best positioned to rally global political buy-in to back efforts such as those of COVAX to see appropriate ratification of a vaccine if made available. Thank you.
Okay, I'm going to let the panelists think about that, and I'm going to let the second student in. So Rika, you are in the MPA program, and you're from India. So Rika.
Thank you, Eric. My question is more around the situation in South Asia and my home country of India, and the fact that this talk has actually been very illuminating, and the things that Dr. Gabriel said about the fact that not a lot of us understand, and there is not a lot of clarity around the fact that the vaccine is not this magical cure to this problem that the world is facing today. And something that I've been seeing a lot in the conversations that are happening in India and South Asia is that people are very complacent.
I was going to agree, it's not my area of expertise at all, governance. But I will reiterate the problem. And I think it's an immense problem. And I think what you're seeing, what strikes me from here in Australia is that the disease is being used in a very complex political way, as almost a pillar of election strategies. So each country is individually each leader is individually touting a vaccine for their own electoral success. And clearly the time scale of in the modern world that we live in, this fast media communication, the time scale of elections, electability is so short. It's on the same time scale as this pandemic, and each leader feels this push for a nationalist, vaccine nationalism, as Hassan very nicely put it, for their own immediate electoral ends, and that's not for the public. That's not for the health of the population. It's for them to be re-elected, and that is really hugely complicating the global response to this. The body that you would expect, that I would expect, as not a politician, would be the WHO to be the key player in this. But they are clearly, there's a huge political problem there. They're being undermined by certain governments. So I haven't got a solution to that question, Hassan. It's a fantastically good question. All I can do is reiterate the scale of the problem, and I think it's a severe one. And I'll just say one other thing. So most things about this pandemic have been pretty predictable, I think. I mean, the way the virus is behaving, it's not unprecedented. There's many precedents, right? It's evolving the way I thought it would evolve. It's evolving in the way it's transmitting the way I thought it would transmit. What I have been surprised about, I'm taken aback by, is the amazing political ramifications of all this, how it's being used as a political football, how it's being used by different countries to attack each other. That I did not see coming, maybe perhaps naively. And that to me is the unprecedented nature of this, that we're playing this out, this pandemic, in an age where the power of leaders and national populism and all fed in with social media is really making extremely complicated and toxic mix. And that is going to complicate public health. That's what's happening. So I have no solution at all. I wish I did, but we have to grapple with it, clearly.
I will just comment on the vaccine demand side and the extent to which I can talk about that. I think that there's an interesting debate right now about herd immunity and how many people need to be immune in order to stop transmission from happening. And of course, that's related to the epidemiological features of the virus, but it's also related to the structure of social contacts across which the virus spreads. And so there's been quite a lot of debate in the scientific literature about what fraction of people are going to need to have the vaccine in order to prevent widespread outbreaks and transmission. So I think to some extent that is relevant here for thinking about how much vaccine we need to make, who gets the vaccine, and how much of it we'll need. So obviously what we've seen with things like measles vaccination dissenters and so on, there are going to be pockets, communities that as a whole don't want to have the vaccine, and they will remain vulnerable to outbreaks. And then there are other areas where we can distribute the vaccine and there will be demand. I think it's going to be, there's still a lot of uncertainty about what that critical threshold will be, and it will be context specific. So it will depend on the structure of social networks and transmission in different contexts. And so I do think that there's still a big, it's still very unclear what that means for how many people need to be vaccinated in order to reduce transmission. And I think that's what Gabriel was referring to earlier in this paper that came out with Brian Grenfell's group. But that's the kind of underlying epidemiological uncertainty that is going to determine how much vaccine we need and what fraction of the population will need it.
Gabriel, you have been on the sort of managing side of this, or working inside government and dealing with some of these issues. How do you see?
That was for the swine flu pandemic. I was in government, and of course, the whole world ended up throwing away about 90% of all the vaccines made. I don't think that we're going to find ourselves in that situation this time round. But I agree with Caroline. I mean, look. If you actually sort of apply the heuristical formula, the simplistic one, and given the the reproductive number that we are looking at, which is somewhere around 3 or maybe even 4, depending on the setting and depending on how many interventions you sort of layer on, and are willing and able to do it sustainably. But let's say that, you take all the brakes off, it's probably closer to 4 than 3. You would, if you assume that everybody mix randomly and equally randomly, then you'd be looking at somewhere around 70-75%. But I don't think actually you need that much because of 2 things. One is because I don't think that people will be completely relaxed. And also, we're not going to be able to roll out vaccines to the entire world's population at the same time. So there will be other brakes put on this pandemic in terms of its transmission while you actually roll the vaccine out. Secondly, the paradox is, the later the vaccine actually gets to you, the higher the chances of the rest of the people around you, or maybe even yourself, would have been already naturally infected and then recovered. And therefore, you would actually have people who around you would actually be a layer of protection as well. And then the other very strange feature of coronavirus is, and I say it with a bit of a caveat, and I'll come to the caveat in a moment, but if you just look at the reported literature, and there are about 2 or 3 reports, one from our group as well, that basically says 20% or 10%, 10 to 20% of the primary index cases actually spread it to 80% of the total caseload. And therefore, the technical term is over-dispersion, kappa, or the coefficient of variation, but actually what it really means is it's clumpy. So most people don't spread it on, but if you do happen to spread it on, then it becomes quite a largish cluster. And therefore, what you really need to do is actually to find those most infectious settings, not necessarily individuals, but settings, and then actually cut those transmission chains. And by similar logic, if you can actually identify individuals who are likely to be in the highest risk settings for spread and then get them vaccinated, then you actually don't need to vaccinate too many other people in the population. So that's what I think Caroline meant by the context and the way that in different societies people mix together.
Have we ever done that for? Have we ever done that for a human disease successfully yet?
That's right. And so
has that been done for that targeted vaccination policy? Absolutely.
And I think that what we're probably looking at is anywhere between 25 to 50%. That would be my rough guesstimate. But as I said, if vaccine confidence happens to be very low amongst the 25 to 50% that you are actually going to vaccinate, then you're in trouble. Because if they actually have low trust in the vaccine, and yet they would be the highest risk individuals in the highest risk settings for spread, then you are in real trouble. Whereas on the other hand, conversely, even if you don't have any trust and you're not going to take the vaccine, but you are never going to actually spread it on anyway because you don't find yourselves in those settings, then we're okay. So I think that it's going to be a different answer for different populations.
Can I ask you a question, Gabriel? Because traditionally when we make a vaccine, it goes to vulnerable groups and clinically relevant individuals, not transmission important people.
Sure.
So obviously we don't know yet whether a vaccine is going to prevent transmission or just prevent disease. And that will be the defining, if we have an infectiousness blocking vaccine, then you could have a strategy of distribution that targets high super spreader events. But just to echo what Eddie was saying, generally speaking, wouldn't that be very politically difficult to do because we always need to give priority to clinically vulnerable groups, right?
Well, I wanted to add, it's also politically difficult to do because to identify the super spreaders and the information that is needed when such high mistrust is there. And I can tell you from studies that have been tried, people don't want to give that information because they don't know what will be done with it. And so I think, particularly given the nature of this disease, where you can be asymptomatic and transmit it, I think that's a really, really high political barrier.
No, I mean, I think that two things. I absolutely agree. And in fact, for I think 7 of the 8 that are currently in phase 3, or 8 of the 9 in phase 3, only one, as I said before, actually has shown some data that it provides sterilizing immunity for the upper airways and therefore potentially blocks transmission. Whereas everything else is actually just disease blocking, not transmission blocking. So I think that if, in fact, we have some vaccines which reduces disease, and then maybe 1 or 2 that actually can block transmission, and if we have enough, then you might actually be able to sort of selectively do this. And secondly, I don't think that we are looking at, people who go to bars or people who would, have slightly different mixing patterns, which they might be either embarrassed or for whatever reason would not wish to disclose. I think what we're looking at is people who actually are essential workers or people who work with a lot of other people occupationally. So, for example, people who work at the retail level, people who work on public transport, people who have to provide essential services, whether they're sewage workers or whether they're policemen or whether they're ambulance men. I think that those are the people that you're talking about. The complicating factor, of course, with coronavirus, in particular this one, is that unlike flu, kids don't seem to be the high transmitters. They might have as high infectiousness, but they're probably less susceptible to actually getting infected in the first place, not just showing very few symptoms. And therefore, overall, actually, if they are less susceptible, even though they might be equally infectious, they are actually not nearly as important a transmission group as in flu. And therefore, even the flu tradition, like in Japan in the 90s, when they preferentially vaccinated kids to protect granny, that's not going to work for COVID. But what might work if we have such a vaccine and that we've already protected the highest risk groups that need to be shielded, then there are occupational groups that we should be doing to protect all of us, not just them.
So can I want to throw in a wrench in that, because exactly the groups you described make up the majority of the population of Kampala, right? The majority of the population of Kampala work in informal retail, face-to-face transaction type work. And that's just, that I think I want to throw sort of the wrench in that just from my own perspective. But I wonder if I can take a stab at the governance questions that were answered. Not because I'm particularly optimistic, actually far from, I'm quite pessimistic, but I probably see two avenues. And the one is sort of taking Risha's point first, which is pushing forth more information. Now, how you get through the noise of fake news, I don't know, because honestly, I think for me, I've realized the power of fake news through this COVID pandemic. I hadn't really been as attuned to it as I have now. But I think the one place, if you could push it through, is the fact that, Eddie, you pointed out how many governments are using this for their political gain. And so if they're, and what a populist world we live in right now. And if we were able to swing that, and so go to the bottom up approach, so the grassroots approach and the demand approach, I actually think that probably is the area I see more faith in right now than the top-down approach. I think the second thing is we have a global collective action problem. I just got a breaking news alert just before here about how China, the US, and Russia are fighting at the Security Council about COVID, and that's not helpful. But I do see some bodies that have really stepped up, and in particular in the African continent, the African CDC really has done a great job doing this. And what they've also used very well is leadership that is not current political leadership, but previous political leadership that has very high respect across the continent. So people like Ngozi Okonjo-Iweala, who is currently running for the WTO, people like Donald Kaberuka, Trevor Manuel, these are people we all respect across the continent, and they're carrying the message. And I think that's really important. The final piece is just on the demand side is, in my student life, I actually looked at the political economy of smallpox eradication, at the time guinea worm trials at eradication, and you know, something that's got lost in the last couple of weeks is Africa was declared free of wild polio, which is like immense for us, right? But it's just kind of got lost in the news. But all of these things were actually like a political problem as opposed to a health problem. And this is, you know, I've spoken on a lot of panels right now for COVID, but it's the first time I'm sitting on a panel with health experts, and it's fascinating to me to hear the health side. And I actually think that's, you know, part of the demand piece, part of the collective action piece, is we're actually going to have to work much, much better together across our disciplines to be able to resolve this. And I still think we're working quite siloed in terms of the research we're doing and in terms of the understanding that we have.
Well, thank you, Astrid. It's music to our ears. This is very much the purpose of this webinar and the whole series of webinars. I wanted to bring in a question that I think a lot of people are asking, and maybe not for the right reasons, but I'm going to bring it in nevertheless. So this, and I think because I think it needs to be responded to. So this is from Wincy Chen. She said, instead of spending all these resources on short-term solutions, lockdowns, vaccines, etc., why can't we grasp the concept of living with the virus? And because we invited this with the title of Living with COVID, and explore new ways of life which may have longer-term impact. So there are several ways of reading this question, but you know, why is it that we don't just want to let this play out in different populations, and why, you know, we see this in rich countries, we see it in poor countries. Why is that we need to address this with policy? Who wants to start?
I'm going to start on this one just with a simple answer. Is that I think it's, I mean, maybe this is the cynic in me, but I think it's actually still too politically relevant as a short-term thing and a short-term tool to want to give in to the sort of long-term, we got to live with it type of thing. You know, we can still win it right now. And I think that's, you know, a very, very powerful political message in a number of contexts, or we can still ignore it depending on which political context.
Yeah. Who wants to go next?
I mean,
Caroline.
I would just say that, you know, not everywhere, but in some countries, COVID has killed an awful lot of people, and you know, continues to be an important cause of mortality. This is a new virus that we don't have immunity to. And so I think, you know, there is justifiable concern that we don't want to let that happen. And, you know, I agree that, you know, the hope is that we will start to restructure our health systems and the way that we live in a way that's more resilient to future pandemics because of this. But I think that there are still many vulnerable populations that have not yet seen this virus really take hold, and the mortality and morbidity that could result, you know, this is preventable. So while I understand that this is not the same everywhere in the world, I do think that it makes sense to confront this with everything we have, keeping in mind that hopefully we can restructure society in a way that is sustainable. And all of these, you know, the infrastructure that's gone up so quickly can be sustained in a more integrated way to address other threats, both endemic pathogens, chronic diseases, but also future pandemics, because, you know, this hopefully will be the last for a long time, but the conditions on Earth right now are such that pandemics emerge and can spread. So you know, yes, I hope that there's restructuring that's sustainable, that will make us more resilient, but I don't think that we should be letting the virus spread willy-nilly. Eddie, do you want to?
I was just going to say, I live in a city of 5 million people. We locked down early, not for very long. We've only had 3 weeks homeschool, okay? And we've had overall, since the start of the year, 4,000 cases in Sydney and about 50 deaths, okay? life is not normal, but it's not far off normal. And I think there the intervention has worked. And so I think if you clamp down early, you do it hard, you can then go back to some degree of normality. Now we're an island, so it's slightly different. New Zealand's even more dramatic. Lockdown very early, lockdown hard. They live effectively normally. Okay, their rugby stadiums are full of supporters. So I think that shows that that strategy, if done properly, can lead you to a place where you can live a normal life. Now, it's different because they're a small country with a small population. They're isolated, so things are a little bit different in countries like that compared to Western Europe, for example, where there's endless travel between all the countries. But I do think it shows that approach has tangible benefits, and it can return you to a lifestyle that we're used to. So,
except Eddie, that's very strongly predicated on your type of work and whether you can do your type of work in that type of lifestyle. And I think that's just
but I'm saying in New Zealand, everybody is living normally, okay? Yeah. Because they've effectively eliminated the virus. In fact, they've done it twice now. It came back and they've removed it. I completely agree. I think they are in a unique situation, and I don't get me wrong, because they're in Ireland a long way and they had more time to prepare, and there's only 5 million people in the country. But it does show you, I think, that strategy works. What would worry me about letting it circulate at high, I think for me, that the place where I was really focused on this was what happened in Italy. Okay, and I think we saw Wuhan, and that was still a little bit, remote in some respects. It's certainly in Australia, but the Italian situation was terrifying to everyone, that we didn't want to get into that situation. And that's why certainly the Western countries started that lockdown strategy, because they didn't want it to hand, I could see parallels to Northern Italy into Sydney and Melbourne. Lombardy was a richest state in Italy, right? It kind of looked like we could have that kind of thing too. And I don't think that we want to let this virus circulate at high levels, because evolution's a sneaky thing, and who knows what it would evolve into. Okay, it could evolve. Virulence could have gone up. Who knows? More infectious. So I do think putting the brakes on it is a good thing to do. But I do completely agree with the premise of the question, that may not be the right thing in every society. I mean, clearly it's, and there are costs to that, right? And I haven't got the answer at all, and that's why I've not really contributed to debates on this, because I do feel that I have enough insight. But it's certainly in this part of the world, the governments have taken it very seriously. Okay, and the population has a response. Caroline shows some very nice statistics at the start, showing that people in New Zealand who were except one more thing. Melbourne, they locked down the whole city for 6-7 weeks in Melbourne. Okay, you're allowed once a day to go and get food, once a day for exercise. They had a poll of how many people supported that, and 2/3 said they believed in it. Okay, so their entire civil liberty has been taken away. The economy is being destroyed. Okay, people losing their jobs, but 2/3 of the population of that city said it's the right thing to do.
Gabriel, do you want to come in on this, or?
No, I think enough has been said on this topic. I mean, I just think that it would be always a three-way tug of war. The three-way tug of war is between health protection, economic preservation, and social consent and the well-being of the population. I mean, the emotional and mental well-being of the population. And these three forces can be, at worst, orthogonal. And if and when they are orthogonal, then it's a very, very delicate dynamic balance that the politicians would need to weigh and then decide which way to go. And I rather suspect that what you need to do is to go in a bit of a yo-yo direction, where you would need to emphasize on one or two of those at any one time, because if they are orthogonal, you cannot have all three. And I think that that's the reality of our new normal for at least the next year or two.
Well, we are reaching the end of this conversation, and I think we have had a proof of this notion, how important it is to have this dialogue between disciplines. We've had economists, we have had virologists, epidemiologists. So this is, I think, been extremely illuminating. And of course, what we have seen is that, yes, this impact will be with us for a long time, and maybe the virus itself will be with us for a long time. But all of you have emphasized the impact on inequality, and that it has amplified already severe inequalities. And I think it has a risk now also, as you have said, that vaccines may even further amplify these inequalities, as Gabriel put it by commission. So, and I think the one thing that again shows this need to have a dialogue is that, and what Eddie pointed out is that he was surprised how this had been used in politics. And of course, Astrid was saying also how fake news have played in and so on. So all these things, I think, suggest that we need to have a much more open dialogue across disciplines and really understand these behavioral changes, these impacts in the political, social arena as well. So thank you very much. I greatly appreciate that you have taken time, and I particularly Eddie, it was very late, and also for you, Gabriel, it's very late. So thank you very much, everybody, and I look forward to continuing this discussion in many different fora. Thank you.
Thanks, Eric.
Bye-bye now.
Thank you.
Thank you.
Bye.
Bye.